Hello everyone. You are able to hear me? Hello. Am I audible? Yes, 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 yes. Am I audible? Yeah. Good afternoon, everyone. I welcome you all for the today's webinar on anatomy of elbow joint. So let's begin. I'll cover the topic under the following headings: the bones forming the elbow joint, articulating surface, type of joint, articular cartilage, synovial lining, capsular attachment, fat pad of the elbow joint, bursae, ligament, movement, muscle, blood supply, nerve supply, cubital fossa, carrying angle, and clinical notes. Now let's begin with the bones forming the elbow joint. Elbow in Latin is also known as cubitus. So you will hear this term. So you will hear this term cubitus related to elbow many of the time. Now the elbow joint is made up of three bones. Elbow joint is made up of three bones: humerus, ulna, and radius. The picture shows here, this is the elbow joint, this is the humerus, this is radius, and this is ulna. This is the lower side of the humerus, and these two are the bones, the radius on the lateral side and ulna on the medial side. Now the lower end of the humerus and the upper end of the radius and the ulna, these bone forms the elbow joint. Now let's see the articulating surfaces. For the articulating surfaces, let's see first the humerus bone. Let's see the bony landmarks on the humerus. This is the medial side and this is the lateral side. On the medial side, we see the medial epicondyle, and on the lateral side of the humerus, you have the lateral epicondyle. This is the green mark here shows the supracondylar ridge on the lateral side and on the medial side. This is the anterior view of the elbow joint, and this picture shows the posterior view of the elbow joint. In the anterior view, we have seen the humerus, the medial epicondyle, the lateral epicondyle, the supracondylar ridges on either of the side. These two are the fossae. This is the coronoid fossa, and this is the radial fossa, which is marked in purple color. This you can see on the anterior surface, and on the posterior side of the elbow joint, here it is the olecranon fossa. Below the coronoid and the radial fossa, there is capitulum on the lateral side and there is trochlear on the medial side. The capitulum is the round spherical structure which is having the smooth anterior and the inferior surface. The trochlear, this is the trochlear, which is the hourglass shaped structure and which is divided into the medial and the lateral part by the trochlear groove. The medial flange of the trochlea extends below the lateral flange, which is basically responsible for the carrying angle formed between the arm and the forearm. So the capitulum and the trochlear, this forms the proximal articulating surface. Now let's see the bony landmarks on the ulna. The ulna is the larger and the medial longer bone of the two of the forearm bones. It is the most stabilizing bone of the forearm. The picture you can see here, let's see the bony landmarks on the ulna. This is the trochlear notch, this is the trochlear notch. This is the coronoid process. Backside you can see the olecranon process, and this is the radial notch of ulna. Now the trochlear notch, this complete trochlear notch articulates with the trochlea of the humerus to form the humero-ulnar joint. The coronoid process lodges into the coronoid fossa during flexion. On the posterior side, you have the olecranon process, which lodges into the olecranon fossa during extension. Just lateral to the coronoid process, there is the radial notch of ulna, which articulates with the head of the radius to form the superior or the proximal radio-ulnar joint, which is a pivot joint and which is involved in the pronation and the supination of the forearm. Now let's see the radius bone. On the lateral side, the radius bone, which is a smaller, shorter, and the lateral bone of the two forearm bones. This is the head of the radius, this is the neck, and this is the shaft. The head of the radius is concave, circular in shape, and you can see a slight depression at the center, which is called the fovea, which articulates with the capitulum of the humerus superiorly to form the which articulates with the humerus to form the humero-radial joint. Anterior margin of the head of the radius gets lodged into the radial fossa of the humerus during flexion. This is the inferior articulating surface, and this is the proximal articulating surface. Now next, the type of the joint. Elbow joint, this is the synovial hinge joint, which it is also a compound or the composite joint, which is divided into elbow joint is divided as a composite or the compound joint, which is divided into the humero-ulnar joint and the humero-radial joint. The humero-radial joint again continues with the superior radio-ulnar joint. All the three, that is the humero-ulnar joint, the humero-radial joint, and the superior radio-ulnar joint, collectively called as the cubital articulation. Articular cartilage. Articular cartilage is the material that covers the end of the bones of any joint. Articular surface of the bones are covered with the hyaline cartilage, which allows the smooth movements at the elbow joint and also act as the shock absorber. Now coming to the synovial lining. The synovial lining is attached to the inner surface of the capsule. This is the lower end of the humerus, this is the radius, and this is the ulna. The green part you seen here, it is the annular ligament. Now the capsule is attached to the inner surface of the capsule and covers the fatty pads in the floor of the coronoid, the radial, and the olecranon fossa. It is continuous below with the synovial membrane of the superior radio-ulnar joint. Capsular attachment. We will see the capsular attachment under two headings, that is first the upper attachment and the lower attachment. Let's see the upper attachment of the capsule. This is the anterior view of the humerus of the elbow joint, and this is the posterior view of the elbow joint. Anteriorly, this is the lower end of the humerus. The capsule attaches to the medial epicondyle, continues above the coronoid fossa, the radial fossa, and goes to the lateral fossa, lateral epicondyle. It extends from the medial epicondyle, going upward above the radial fossa, the coronoid fossa, and then going laterally to the lateral epicondyle. This is on the anterior view. Now let's see on the posterior view. The capsule is attached to the margin of the olecranon process, extending from between the medial to the lateral epicondyle. This is the upper attachment of the capsule. Now let's understand the attachment on the lower side. This is the head of the radius, and this is the ulna. The green part shows here is the annular ligament. This is the coronoid process, and this is the olecranon process. Now the capsule extend from the anterior and the medial margin of the coronoid process. It is attached to the anterior and the upper margin of the annular ligament on the radial head, continues posteriorly with the annular ligament, and then continues with the margin of the olecranon process. This is the attachment, capsular attachment on the lower side. Now the capsule is relatively thin anteriorly and posteriorly to allow flexion and extension movement. Sides of the capsule are thick and is supported by the ulnar and the radial collateral ligament. Next is the fat pad of the elbow joint. These are the protecting structures of the elbow joint. There is the anterior, and this is the posterior fat pad. They serve as a reserve of cells for the ligament and tendon repair, and are the cells responsible for the inflammatory responses. Next is the bursae. Bursae is a membranous structure, is a membranous sac filled with the synovial fluid. It acts as a cushion to reduce friction between the moving parts of the joint. Mainly, there are three bursae seen in the elbow joint. These are the intratendinous bursa, the subtendinous bursa, and the olecranon bursa. This is the lower end of the humerus. This is the ulna. This is the olecranon process. The structures you see here. This is the triceps muscle, which is attaching to the posterior side of the olecranon process. This, in the intratendinous bursa, it is located within the tendon of the triceps brachii muscle. The subtendinous bursa is present between the olecranon, this is the olecranon, and the tendon of the triceps brachii muscle, reducing the friction between the two structures during flexion and extension of the arm. The subcutaneous or the olecranon bursa, which is present on the dorsal triangular surface of the olecranon process. Let's see the ligament. There are mainly two ligaments, the ulnar collateral ligament or the medial collateral ligament, the radial collateral ligament or the lateral collateral ligament. Let's see the ulnar collateral ligament. Now the picture shows here, this is the medial view of the elbow joint. This is the lower end of the humerus. This is the ulna, the coronoid process, and this is the olecranon process. Now, the ulnar collateral ligament or the medial collateral ligament has three bands: the anterior band, the posterior band, and the inferior band. Now the anterior band is attached to the anterior margin of the medial epicondyle to the margin of the coronoid process. This is the anterior band. It is the strongest band and it resists against the valgus force. That is, it gives the valgus stability. The posterior band is attached from the posterior margin of the medial epicondyle to extending to the olecranon process. This is the posterior band and it limits the extension force. This is the inferior band, the oblique band or the transverse band. The inferior band is stretching between the olecranon process and the coronoid process. It is attaching to the anterior band and the posterior band. It helps in joint approximation and it is also known as the Cooper's ligament. The blue part which you see here, this is the intermediate band. It is the gap between the anterior and the posterior band. So this is the ulnar collateral ligament, the anterior band, the posterior band, and the inferior band. The anterior, posterior, the inferior, and this is the intermediate band. Next is the radial collateral ligament. This is the lateral view of the elbow joint. This is the lower end of the humerus, and this is the radius. Green line shows here the annular ligament. The lateral collateral ligament comes from the lateral epicondyle and merges to the upper margin of the head of the radius. This is a fan-shaped triangular ligament and it provides the varus stability. We have one more ligament in this, that is the annular ligament. The annular ligament circles the head of the radius anteriorly and posteriorly, and it permits the free rotation of the head of the radius. It holds the head of the radius tightly. Next, see the movement. The movement at the elbow joint are the flexion and the extension. The flexion, when you bend the elbow, this is flexion and it is range of motion is 0 to 140 or 150 degree. And this is the elbow extension. When the arm and the forearm assumes a straight line, this is the extension. Extension is the close pack position of the elbow joint. The pronation and the supination occurs at the proximal radio-ulnar joint. The video here you can see it is the flexion and the extension at the elbow joint, and this is the pronation and the supination at the elbow joint. Next is the muscles. The chief flexors of the elbow joint are the biceps brachii, the brachialis muscle, which is innervated by the musculocutaneous nerve. The brachioradialis assists the chief flexors and acts best when the forearm is in mid-prone position. It is innervated by the radial nerve. Extension is the chief extensor is the triceps brachii muscle, which is innervated by the radial nerve, and the enconeus assists the chief flexors. Next is the blood supply. Blood supply is by the anastomosis around the elbow. That is the brachial artery, the ulnar artery, and the radial artery. Nerve supply is by the radial nerve, the musculocutaneous nerve, the ulnar nerve, and the medial nerve. The radial nerve supplies the forearm muscles, all the extensor compartment muscles. The musculocutaneous nerve supplies the arm muscles, the ulnar nerve, and the medial nerve supplying the forearm muscles, the flexor compartment muscles. Next is the cubital fossa. This is the important area or the structure seen in the anterior compartment of the elbow. Now, cubital fossa is an important area of transition between the arm and the forearm. This is the arm, this is the forearm. It is a triangular hollow depression located in front of the anterior part of the elbow, and it is homogeneous with the popliteal fossa of the knee joint. Let's see how the cubital fossa is formed. We have the border, the apex, the base, the roof, and the floor. Let's see the boundaries of the cubital fossa. The lateral border, this is the arm, this is the forearm, this is the cubital fossa. The lateral border is formed by the medial border of the brachioradialis muscle, which arises from the lateral supracondylar ridge of the humerus. This you can see here, the brachioradialis muscle. This is forming the lateral border of the cubital fossa. The medial border is formed by the lateral border of the pronator teres, which arises from the medial epicondyle of the humerus. This is the pronator teres, which is forming the medial border. The base, the yellow line, is formed by the superior, it is the superior and the horizontal line passing through the two epicondyles of the humerus, the medial and the lateral epicondyle. The apex is downward, and it is the meeting point of the brachioradialis and the pronator teres muscle. The roof of the cubital fossa is formed by the skin. When you retract the skin, you see the superficial fascia containing the medial cubital vein, the medial cubital vein joining the cephalic vein and the basilic vein. Then you see the lateral cutaneous nerve of the forearm and the medial cutaneous nerve of the forearm. Then you have the deep fascia and the bicipital aponeurosis. These all structures forming the roof of the cubital fossa. In this picture, you can appreciate the bicipital aponeurosis. Next is the floor of the cubital fossa. The floor of the cubital fossa is formed by the brachialis and the supinator muscle. The brachialis on the medial side and the supinator on the lateral side. Let's see the content of the cubital fossa. The content of the cubital fossa from lateral to medial. First, we have the radial nerve, the tendon of biceps brachii, the brachial artery, and the median nerve. First is the radial nerve. It passes underneath the brachioradialis muscle, which forms the lateral margin of this fossa. It divides into the superficial and deep branch. See, this is the radial nerve. The superficial branch continues into forearm deep to the brachioradialis muscle. The deep branch passes between the two heads of the supinator muscle to reach the posterior compartment of the forearm. Second is the biceps tendon. It runs through the cubital fossa, attach itself to the radial tuberosity along with the bicipital aponeurosis. Next is the brachial artery. The brachial artery bifurcates into the radial and the ulnar artery at the apex of the fossa. Then we have the median nerve. The median nerve lies medial to the brachial artery. It leaves the cubital fossa between the two heads of the pronator teres muscle, and it supplies the majority of the flexor muscles of the forearm. Next is the clinical significance of the cubital fossa. For the blood pressure measurement and the brachial artery pulse, for the venipuncture and the supracondylar fracture. Now, during BP measurement, the stethoscope is placed over the brachial artery in the cubital fossa. The artery runs medial to the biceps tendon. The brachial pulse is palpated just medial to the biceps tendon in the cubital fossa. The venipuncture, cubital vein is often the choice for the intravenous injection. For the supracondylar fracture, it is a common fracture in the young patient, occurs when a person falls on the hyperextended elbow. It is a transverse fracture spanning between the two epicondyles. The displaced fracture fragments may impinge and damage the contents of the cubital fossa. Direct damage or post-fracture swelling can cause interference to the blood supply of the forearm from the brachial artery, resulting into Volkmann's ischemia. Next is the carrying angle. The carrying angle is defined as the angle between the longitudinal axis of the arm and the forearm. This is the arm and this is the forearm. This is the imaginary longitudinal axis between the humerus, and this is the on the forearm. Now, when your arms are held out at your side and your palms are facing forward, and your forearm and hands should normally be about 5 to 15 degrees away from your body. When the elbow is extended and the arm and the forearm do not lie in a straight line, rather the forearm is deviated slightly away from the body. So the angle formed here, this is called the carrying angle. It is prominently seen when the elbow is extended and supinated and disappears during elbow full flexion and pronation. The carrying angle varies from 5 to 15 degree. Carrying angle in males, it is 10 to 15 degree, and carrying angle in females is more than 15 degree. Carrying angle is greater in shorter person compared to the taller person. Let's see the factors responsible for the carrying angle. This is the anterior view of the elbow joint. This is the humerus, the radius and ulna. This is the trochlea. Now, the trochlea, as I have said before, it is divided into the medial and the lateral flange. The medial aspect of the medial flange, the medial aspect of the trochlea extends more distally than the lateral. Therefore, this shifts the medial aspect of the ulna trochlear notch more distally, and this in turn causes lateral deviation of the ulna in relation to the humerus. So these are the factors responsible for the carrying angle. Now let's see the deformities. Cubitus valgus. It is a deformity in which the forearm is angled out away from the body when the arm is fully extended. There is increase in the carrying angle and it varies from 3 to 29 degree. The causes of the cubitus valgus is the congenital condition and the fracture. In the congenital condition, we have the two factors, the Turner syndrome and the Noonan syndrome. The Turner syndrome is a chromosomal disorder in which A female is born with only one X chromosome and has shorter stature and delayed puberty. In Noonan syndrome, it is caused by the genetic mutation that results in the delayed development. The fracture, it occurs as a complication of the fracture of the lateral condyle of the humerus. Next is the cubitus varus deformity. It is a deformity due to the malunion occurring as a complication of the supracondylar fracture of the humerus. It occurs in only extension type of supracondylar fracture of the humerus, causing reduction or loss of carrying angle. The deformity. Next is the cubitus varus deformity. It is the deformity. It is due to the malunion occurring as a complication of the supracondylar fracture of the humerus. It occurs in only extension type of supracondylar fracture of the humerus, causing reduction or loss of carrying angle. The deformity seen here is the Gunstock deformity or the bow elbow. The picture shows here the goniometer measurement of the carrying angle. Benefits of the carrying angle: it avoids the direct contact between the hip and the elbows during walking or when you are carrying the heavy load. Clinical notes in the elbow joint. Common injuries to the elbow joint include the fracture of the bony structure contributing to the joint. Care must be taken when diagnosing a fracture of the elbow joint with respect to the age of the patient. This is because the secondary ossification center in the children and the adolescent can be easily mistaken for a fracture on a radiograph. The approximate age and some of the areas of secondary ossification are as follows. The capitulum at 1 year, the radius head ossify at 5 year, the medial epicondyle at 5 year, trochlear at 11 year, olecranon at 12 year, and the lateral epicondyle at the 13 year. This you can appreciate in this picture. Next is the supracondylar fracture of the humerus. It is the transverse fracture above the level of the humeral condyle, mostly commonly occurring in the children. Transaction of the radial or the ulnar arteries. Adult patient may transact the radial transaction of the radial or the ulnar arteries. Adult patient may transact the radial or the ulnar arteries because these vessels are relatively subcutaneous. Pulled elbow is a disorder that typically occurs in children under 5 years of age. It is commonly caused by a sharp pull of the child's hand. The ligaments can be overstretched and the radius bone partially slips out of its normal position at the elbow joint. The fracture of the head of the radius. It is a common injury that occurs with a fall on the outstretched hand. Next is the epicondylitis. We have the lateral or the medial epicondylitis. The lateral epicondylitis occurs due to the inflammation, soreness, or pain on the lateral side of the elbow, usually seen in patients who perform the manual labor or the sports which require twisting and extension of the wrist against the resistance. Medial epicondylitis, it is the inflammation or the soreness or pain on the medial side of the elbow. Pain due to repetitive overuse or the overload activities, which is aggravated by the movement of the wrist. So the lateral epicondylitis and the medial epicondylitis. The lateral is called as the tennis elbow, and this is the medial epicondylitis, which is called the golfer's elbow. Next is the arthritis. Osteoarthritis is common, extremely common. Next is the ulnar nerve injury. Posterior to the medial epicondyle, the ulnar nerve compresses at the elbow. This is called the cubital tunnel syndrome. It is the condition that involves pressing or stretching of the ulnar nerve, which can cause numbness or tingling in the ring or the small finger, pain in the forearm, and or weakness in the hand. These symptoms are often felt when the elbow is bent for an extended period of time, such as holding a phone or while slipping, pulling, reaching, or lifting. Thank you.